So I invite Dr. V.K. Shah to speak on stem cell and percutaneous coronary interventions.
Yeah, good afternoon, Chairman and my friends. I think, I don't know, this topic is probably a misfit in this symposia. The symposia says on PCI, and I don't see any relation between stem cells and PCI, barring some few anecdotal reports which are reported increased neointimal growth in patients who have undergone PCI with bare metal stents. Barring that, there is nothing related to PCI. And therefore, what I would speak now is stem cell therapy following an acute myocardial infarction where you have thrombolized or you have done a primary angioplasty or PCI intervention already. So, just to recapitulate, acute myocardial infarction is defined as death or ischemic necrosis of myocardial cells, and the irreversible cardiomyocyte injury begins immediately after 15 to 20 minutes of coronary occlusion, leading to loss of systolic function and eventual scar formation. The current treatment of an occluded artery is reperfusion techniques, and that is by fibrinolytic agents or by angioplasty. Unfortunately, at least in this part of the world, most of these strategies are not translated into real-world practice and often are too late to exert any comprehensive tangible benefits. Why only this country? Even in Western countries, there are only 3 to 4% of the patients who come in golden hour, and only 20% of the patients receive PCI in the first 3 hours following chest pain. Therefore, these techniques fail to salvage enough myocardium. Now, this was a very landmark paper by Linkoff and Topol, written in, I believe, 1993 in Circulation Journal, where he mentions, title is Illusion of Reperfusion. Does anyone achieve actually optimal reperfusion during acute myocarditis? This was at an era when thrombolytic therapy was at its peak, Even he says, in fact, only the unusual patient appears to achieve optimal reperfusion for acute myocardial infarction, with a substantial deterioration of benefit in many patients due to insufficient early or rapid recanalization, incomplete patency with TIMI grade 2 flow or critical residual chronic stenosis left behind, absence of myocardial tissue reflow despite epicardial artery patency, intermittent coronary patency, subsequent reocclusion or reperfusion injury. So even in that era when fibrinolytic therapy was at its peak, only 25% of the patients actually got optimal reperfusion. Rest of them still had less perfusion of flow after an AMI. And now in 2010-12, when angioplasty or primary angioplasty at its peak, if you do pre-TCA or pre-CI in 100 patients of STEMI, you have only 35 patients left with a TIMI 3 flow with a optimal myocardial blush grade, which should be at least 2 or 3. And we know from studies, sorry. Oh, this is not supporting the slides. This hard disk doesn't support some of the slides. Anyway, infarct size after AMI and survival. We know that left ventricular function is a single important determinant of long-term survival for an AMI, And most of the strategies that we are doing today of angioplasties with adjunctive pharmacological therapy can salvage, in the best of the literature, only 3 to 4% of the myocardium at the end of 6 months. That is, those patients who get reperfused within 3 hours or 4 hours, only 3 to 4% of the myocardium gets salvaged, which means that you leave lot of myocardial scar behind, and therefore a long-term survival rate may not change. So contemporary issues in AMI is that you want to salvage more myocardium that is lost after total coronary occlusion, where our current therapies have not been able to salvage enough myocardium. And therefore, we are in search of improved approaches, And what are the improved approaches? And this is our crystal ball, The possible strategies are, in addition to your primary angioplasty and adjunctive therapy pharmaco, we need to precondition or post-condition the myocardium before he gets an occlusion or after an occlusion. You can give pharmacotherapy to inhibit the risk pathways and another pharmacological approaches which may help to salvage more muscle and gene specific and the newly based cell based. Among all these strategies, cell based seems to be a more rewarding therapy probably in terms of salvaging the muscle or regenerating the muscle. Why stem cell therapy? Why? It has been proposed that a natural system of repair exists in the body, but is overwhelmed by the substantial damage that can occur after a sudden thrombotic occlusion of a main artery. The concept of repair in AMI has been from the following facts. Male patients who received the female hearts, and when those patients died and you had the biopsy done of the heart, we saw Y chromosome in those hearts, suggesting that there was some mechanism which was homing the cells from the male heart onto that female heart. Presence of stem cells have been noticed on autopsied heart after MI by Beltrami and all. So also resident cardiac stem cells have been found by Haley and all. So this led to the concept that there is probably some mechanism which is trying to repair the damaged heart when it occurs. But it is not sufficient probably. Following this concept, there were some preclinical studies or experimental studies done on animals, small animals, and then later on big animals. And one of the most important trial was done by Orlick and al. In 2001 when they injected the autologous stem cells, hematopoietic stem cells from the mice after injuring the myocardium, and they found that there was 40% of regeneration of the muscle tissue after injecting those cells. And then there was another study by the same person, Jackson, Coker, in peripheral diseases, etc. What are the mechanisms which may augment the heart functions? These are all postulations and may not be true also. But when we give stem cell therapy either in the form of bone marrow stem cells, endothelial progenitor cells, fetal cardiomyocytes or skeletal myoblast, we can attenuate or inhibit the post-myocardial modeling by decreasing the infarct expansion which is caused by increased collagen expression, increased angiogenesis. Myocardial preservation also can be improved because of increased angiogenesis and inhibiting the apoptosis, and possibly myocardial regeneration by myocyte regenerations. So these were the postulation or the hypothesis how the stem cells may be. After the Orlick trial, the cardiologist became bullish. 2001 published, and 2002 onwards we had many trials, clinical trials on the human beings following stem cells implanted onto the myocardium either by intracoronary route or by during surgery. And there were so many trials, and all of these trials showed some benefit at the end of 30 days or 6 months. Can somebody help me? How the... No. So following the experimental trial and the initial clinical trials on human beings, which showed, if not substantial, there was a further improvement of myocardial salvage by another 3 to 4% in most of the trial. And a meta-analysis of these various trials done, all of them studied by various modalities, either by MRI, SPECT or LV or echo. All of these studies showed an improvement of ejection fraction of around 3 to 4% over and above what you have already gained by doing a primary PCI with adjunctive pharmacotherapy. But this was not enough probably, just 3 to 4% of myocardial salvage, and therefore the stem cell therapy did not get a boost. But the current articles, so again this computer doesn't support the slides, all of them. So there was a paradigm shift.
Why is
in
this
2012? In 2012, there's a slide coming after this. Yeah, this one. Okay,
I just like to make one announcement, which is a very important announcement, that the lunch will be served after 1:30. We are going to have a very, very important keynote address by Dr. Mukesh Hariawala after V.K. Shah finishes. So I'll request all of you to please stay on. This is going to be a very prestigious session of the conference.
And then there was a paradigm shift, You can see that in 2012, there were 2 articles published, one in JACC and probably one in Lancet. The CPO trial and the Caduceus trial. Both of these trials did put intracoronary stem cells therapy, intracoronary stem cells, which were derived from the cardiac stem cells by biopsy and culturing those cells. And for the first time, the myocardial salvage was seen in double digit, more than 10%. Not only that, these were the 2 trials which actually showed the decrease in the contractile scar, decrease in the scar tissue to the tune of almost 24%, which persisted till 1 year. So these were the first 2 trials probably which showed an improvement on EVF in the double digits, also showed by the best modality of diagnosis, imaging, a reduction in the contractiles, in the scar tissue of almost 25%. And what are the unresolved issues of stem cell therapy? Number, we are still in infancy and there are a number of issues which need to be resolved. What are the cell types which needs to be given to these patients? What is the number of cells required? Method of delivery? What are the optimal timing for transplantation? Immunogenicity? Ethical considerations? Safety, efficacy of course is now proved beyond doubt, at least for the autologous cells. Cell dissemination and what are the associated side effects? Survival benefits versus symptomatic improvement, optimal candidate for treatment, cell transplantation in non-ischemic heart failure. And what are the new things which are on the horizon? The new lines of research to improve the cell survival rate in the ischemic myocardium, which is one of the harbinger, of why the stem cells are not that very effective, and therefore you need to improve the internal milieu where our stem cells can survive more. Modification of the target organ regions by low energy shock waves or ultrasound mediated destructions of microtubules in the coronary, which will help in retaining or which will help in the retention of our stem cells which are implanted into it. Cytokine and paracrine factors that will favorably affect the angiogenesis, inflammation, cytoprotection, metabolic modulators and apoptosis, use of different sources of pluripotent cells like embryonic stem cells, spermatogonial stem cells, and oocytes, etc. And rejuvenating the weaker cells due to comorbid conditions with the help of pro-survival genes. So in conclusion, myocardial salvage, which determines the long-term survival of AMI, requires not only restoration of blood supply as we do today, but will also require replacement of the myocytes. Multi-center randomized trials needs to be targeted to address the impact of cell therapy on important outcomes and long-term event-free survival as compared to the conventional therapy which is recommended. Thank you.
Thank you very much, ladies and gentlemen. I think we have 3 important sessions. I'll request Dr. Anand Khanna to make some comments or concluding remarks.
This was a good talk, but as of now, all over the world, we have no consensus on using stem cell, whether autologous or from other sources, for acute MI or even for ischemic cardiomyopathy and other non-ischemic cardiomyopathies. I know that in India, many centers wanted to try this, and we did not have any permission from the Drug Controller General, and most of the trials have stopped, not only in India but also abroad. I think the next session would be addressing a lot of issues on angiogenesis, also on issues whether these stem cells are useful, whether they can, the myocytes which are regenerated, whether they properly electrically couple with the remaining myocardium, and whether this leads to more arrhythmogenicity or not. So those are the issues probably which will be discussed in the next talk. All the three speakers spoke very well, and still, even at the end of the talk, you would realize that all these three issues remain a challenge, and we do not have real answers for this, and this is the way the research is going on, and going to go on for another 10 years or 15 years to conquer these sort of problems in coronary interventions.
Let's give a big hand to all the speakers for their outstanding presentation.